hope we can meet again soon, and looking forward. Thank you very much for inviting me to be part of the distinguished course. Thank you, Werner, very much. Thank you, Henry. Thank you, Zohdi, very much, Ihab and Mohammed. I'm very happy to be part of this very distinguished course, and hopefully I will be able to convey and complete the work of Professor Werner. We understand that the transnasal endoscopic skull-based surgery needs team work, including definitely the neurosurgeons, in addition to the rhinologists. I'm very lucky because after the lecture of Professor Hosman, we realized how important we have to work together to offer the patient not only effective surgery and take care of the lesion, but also to offer him good quality of life post-operative and take care of the function of the nose as if I just want to add the battery. So this usually leads to the effective and safe endoscopic sinus surgery. So the co-work between the rhinologist and the neurosurgeon is very important, very, very important, and is the best tool to reach safe and effective endoscopic sinus surgery. So the aim of work of this presentation is basically to demonstrate endoscopic and radiologic anatomy of the lateral nasal wall and anterior skull base, paving the way for the proper management of skull-based lesions, and at the same time offering safe and effective surgery. Not only effective, but also safe, and at the same time with better quality of life. We have to go to the basics. We have the inferior turbinate, the middle turbinate, and the superior turbinates. These three terms are definitely the anatomical clue and the anatomical landmarks through our work. And we understand that we have the inferior meatus, middle meatus, superior meatus, and sphenoethmoidal recess. These recesses are underneath the terminus and then between the superior turbinate and skull base. One of the most important slides is this one showing the bulla. The bulla is the bulla. The bulla is the core or our center of work during taking care of the lateral nasal wall. And we have the answer process. The answer process is located anterior and inferior to the bulla. This is very important relation. And we have here the skull base or the roof of the ethmoid, the fovea ethmoidalis, and behind we have here the basal lamella, which is part of the middle turbinate. So we have the anterior ethmoid just anterior to the basal lamella, and then we have the posterior ethmoid behind. We understand that this is the middle turbinate covering the osteometacomplex. If we remove the middle turbinate, we will expose the osteometacomplex. Back, the middle turbinate. Removal of the middle turbinate exposes the osteometacomplex. Accordingly, if you want to proceed to the posterior ethmoid, which is located behind the second part of the middle turbinate, we have go through the anterior ethmoid here, and then the basal lamella into the posterior ethmoid. The posterior ethmoid is covered here by the superior turbinate. The superior turbinate is a tiny structure, but very, very, very important anatomical landmark, but at the same time, very important functioning smell organ. So never and ever to remove this superior turbinate except if it is extremely indicated. Then we have here the sphenoid sinus. We have to understand the sphenoid sinus is located not only behind the posterior ethmoid, but also below in most of the cases. So always, if you want to visit the sphenoid sinus, always inferior and medial, never and ever superior and or lateral. Otherwise, you will get lost either into the cranial cavity or into the orbital cavities. So one should be aware of the basic anatomy and then the cellular Going back into the osteometal complex anatomy again, we have here the bulla. The bulla is the bulla. The bulla is the core. We have to understand very important relations. The frontal sinus ostium is located up at the bulla onset angle, anterior and superior. So whenever you are going to handle any lesion along the skull base in this area, be careful not to block the opening of the frontal sinus. Otherwise, you will induce, unfortunately, the post-operative itis, pyoceal, or mucocele. One of the most common complications during endoscopic surgery and skull base surgery. Then we have the maxillary sinus. Whenever we follow the onset process posteriorly, we usually identify the maxillary sinus ostium. Again, avoid blockage of the ostium. We have here the hiatus seminaris inferior between the onset process and the bulla. Very important to understand this anatomical structure to be able to go through that trans-ethmoid approach to the skull base, which is utilized in many, many cases. And then we have here the hiatus seminaris superior. So the hiatus seminaris inferior is between the bulla and the onset process. Here we are, anterior and inferior. The hiatus seminaris inferior is located between the bulla and the skull base superiorly and the basal lamella posteriorly. Then we have here the infundibulum. The infundibulum is the space, the door of which is the hiatus seminaris inferior. This space is the space between the bulla, ethmoidalis, and the onset process. Usually we can follow the infundibulum, anterior and superior. Usually you identify the frontal recess. The frontal recess is the entry into the frontal sinus, into the frontal sinus proper via the ostium. And then we have here the lateral sinus. The lateral sinus is nothing but the space between the skull base, bulla, basal lamella, bulla, the door of which is the hiatus seminaris superior. In fact, this lateral sinus is divided into a suprabullar and retrobullar recesses. The suprabullar recess is the part of the lateral sinus between the skull base and the bulla. The retrobullar recess is the part of the lateral sinus between the basal lamella and the bulla. So anatomy again. One should be aware of the anatomy. I just want to make sure that you be able to identify this. We are on the left side, nasal septum, middle termit, diagnostic endoscopy. Here we are, this is the onset process. We are between the middle termit and the lateral nasal wall, the middle meatus. Now we are identifying the onset, the bulla, and in between the hiatus seminaris inferior. And according, hop, anterior and inferior, hop, that's the way into the maxillary sinus ostium. Here we are. That's the way into the frontal sinus ostium at the bulla onset angle anterior and superior. Then we follow this. Just want to make sure that you are aware that you have to direct your tool inferior and lateral, never and ever superior and lateral. Otherwise, you will get lost into the orbit. And then I just want to make sure that everybody is aware. This is the middle termit, first part. This is the bulla, ethmoidalis. This is the onset process on the left side. And now we are hitting. This is the first part. The structure, which is nothing but the second part of the middle termit, the basal lamella. Hop, and we are pushing the bulla to expose the basal lamella. So it's the anatomy again. One of the cadaver dissection done at Cairo University with Professor Ahmed Zohdi. Here we are. This is the inferior termit, the mega large inferior termit. Very important section during endoscopic surgery, creating flaps and so on. This is the middle termit. What we did here, nothing, but we everted the middle termit superiorly to expose the osteometal complex. And then the tiny superior termit. The tiny superior termit is very important landmark, anatomical, and at the same time, very important smell organ So never ever to sacrifice it, cauterize it, remove it, excise it, except if absolutely indicated. Then we understand here we have the bulla ethmodalis, and then the answer process, and then in between this is the infundibulum and the hiatus seminaris inferior, and then this is the lateral sinus, hiatus seminaris superior, and then we have here the maxillary sinus. The maxillary sinus, here we are bulla answering angle posterior and inferior, and then we have here the frontal sinus. The frontal sinus is at the bulla answer angle, here we are superior and anterior. So it's the anatomy, and anatomy again. We are revising the anatomy. We want to perform effective surgery, taking care of the pathology, but at the same time, we have to respect the integrity of the anatomical mucosa, anatomical structures, the passage and the aeration and the drainage of the sinuses. Again and again, dry skull. Here we are, the first part of the middle termen, the second part of the middle termen, basal lamella, third part of the middle termen. Here we are, skull base, lamina papyracea, palatine bone, perpendicular plate of the palatine bone. We have here the bulla just anterior to the basal lamella. We have here the posterior ethmoid just behind the basal lamella. The basal lamella is nothing but the second part of the middle termen. And then we have here the answer process, anterior and inferior to the bulla. And then we have here the agar cell. The agar cell is no more than one of the anterior ethmoid air cells, just anterior and superior to the answer. All the air cells anterior to the basal lamella, anterior ethmoid air cells. All the air cells behind the basal lamella, the posterior ethmoid air cell. And then we have here the hiatus maxillaris, within which we have the maxillary sinus. Usually in cadaver dissection, and in life surgery, we understand this is covered by mucous membrane, nasal mucosa, maxillary sinus mucosa, with the opening of the maxillary sinus inside. Usually behind the answer process, if you found any opening in front of the answer process, it's an accessory ostium. And then we have here the frontal sinus ostium. The frontal sinus ostium is located at the bulla answer angle, anterior and superior. The anatomy again, working together with the rhinologist definitely will help you offer a very good chance to get effective and safe endoscopic sinus surgery. Then we have the sphenoid sinus just behind and the sella up and posterior. So it's the anatomy, the dry skull, definitely the cadaver dissection is very, very important. Whenever we are going to work inside the nose, we have to understand our lamellae, our depth. So we understand usually we face the answer process. Usually we do not depend on measures, maybe 3 centimeters, 3.5, the anterior wall of the bulla, the second lamella, and then the basal lamella. The basal lamella is very important passage into the posterior ethmoid. We have the answer level, the anterior wall of the bulla, the basal lamella, and then the anterior wall of the sphenoid sinus. Very important. This is nothing but the axial diagram. Here we are. This is a sagittal diagram, the answer process, anterior wall of the bulla, and then the basal lamella, and then the face of the sphenoid. One should respect the depth. We can reach the answer, and then we can go into the anterior wall of the bulla, removal of the bulla. We can proceed into the basal lamella. Opening the basal lamella, we'll go into the posterior ethmoid. Then we can reach the anterior wall of the sphenoid sinus. We can marsupialize or widen the ostium, communicate the ostium with the opening via the posterior ethmoid, and then we are inside the sphenoid. Whenever you are going to hit the posterior wall of the sphenoid, stop. We have to understand where to stop before it's too late. Never and ever hop. We are inside the posterior cranial fossa, except if you are planning to take care of a chordoma, of whatsoever meningioma, whatsoever a lesion up there, working together. Now, the parasagittal cut, one of the most important presentation of where we have to go the answer process level, followed by the anterior wall of the bulla. Here we are. The anterior wall of the bulla is a very important guide to the anterior ethmoid artery. The anterior ethmoid artery should be respected whenever you are planning to go up there and cauterize it. You want to take care of the skull base up there, but be careful not to cut it. Otherwise, it may retract into the orbit. Retraction of an anterior ethmoid artery into the orbit may lead to orbital hematoma. Orbital hematoma, sometimes it's nothing, but in most of the cases, it's dangerous. And in some cases, it may proceed to blindness. So one should avoid, and one should be aware, and one should be experienced of how to handle this. So we understand the first lamella, the answer process, the face of the anterior wall of the bulla, the anterior ethmoid artery, and then the basal lamella, and then the face of the anterior wall of the sphenosinus. We understand the posterior ethmoid artery up there, especially if we are going to take care of a meningioma. We have to be aware where to identify the posterior ethmoid artery and cauterize it to decrease the blood supply of the lesion. So it's the anatomy, and anatomy again. I believe this is one of the most important slides to be discussed together as neurosurgeon and rhinology. Whenever you are going to work up or inside the nasal cavity, one should study and restudy the skull base. The CT should be there. We may have the MRI definitely as well, but we have to study the skull base. The skull base should be well studied. Why? Because the CSF leak may be there, the lesion may be up there. If we're going to take care of this skull base, the configuration should be borne in mind beforehand. So according, we have here the crista galli, we have here the crista galli, we have here the nasal septum, we have here the nasal septum, and then we have here the middle turbinate, the first part of the middle turbinate, here we are. And then in between, we have the cribriform plate. We have here the cribriform plate. And then we have the very tiny, very thin lateral lamella, part of the ethmoid bone. We have here the very thin lateral lamella. And then we have the relatively thick fovea ethmoidalis, frontal bone. The relatively thick fovea ethmoidalis of the frontal bone. And we have here in between the exit of the anterior ethmoid artery, we have here the exit of the anterior ethmoid artery. So the anatomy again, one should appreciate how high the fovea is and how low the cribriform is. So one should be aware of the anatomy again. And here we are, how thin the lateral lamella is and how thick the fovea is. One of the most common sites of an CSF leak or entry into the skull base is via the lateral lamella. One should be aware of the level. So whenever you are going to work up there, be careful. Be careful. Why? Because whenever you are going to take care of a pathology here, sometimes here we are, pathology here, you are taking care of the pathology. Be careful. If you are going that way and taking the pathology, stop. You have to stop up there. If you took that level and go up there, you are visiting nothing but the skull base. So you have to be aware of this and careful of that. So the anterior ethmoid artery is up there and the anterior ethmoid artery is here. You have to study and be able to realize the shape of the skull base, anterior skull base, the level of the different structures, and the thickness of the different structures. Right, left may be completely different. And here we are. We can understand on the right side, we have here, looks like a step ladder. On the left side, it's definitely slope. So don't take the right side for the left or vice versa. Otherwise, you may get into the skull base and induce iatrogenic CSF leak. We are lucky together because we have the dry skull. We can identify the middle turbinate, first part, the middle turbinate, second part, the first part vertical, the second part corona. Here we are skull base attachment, and we understand the crista galli is up there, and then here we are. This is the cribriform, and then we have here the middle turbinate. You see here the perforation of the olfactory fibers, and then the very thin lateral lamella and relatively thick fovea. If you want to realize how thin these structures are, you can just apply light from below. Here we are. This is the mid-termit, and accordingly, we can identify here, this is the mid-termit, and then the very thin lateral lamella, here we are, and relatively thick fovea. So we have to be aware how thin, how high are these structures in that particular patient based on the CT preoperative. One should be aware that the lateral lamella may be nothing but up to 3 millimeters, up to 7 millimeters, and up to 13 millimeters. In such a case, it's very liable for insult during any maneuver up there. One should be very careful. And here we are the type 1, type 2, or the very, very, very long lateral lamella. Again, anterior ethmoid artery, posterior ethmoid artery. The anterior ethmoid artery along the anterior wall of the bulla. In most of the cases, we realized with the very good examples, Professor Huseman showed us the variations, a lot of variations. So we have to study the CT and then the posterior ethmoid artery along usually the face of the sphenoid sinus. And now one should be aware in the coronal cut where is the anterior ethmoid artery, the medial rectus, superior oblique, and the dimple up there, medial rectus, superior oblique, the dimple, here we are, or the tip of the pyramid. And here we are, this is the direction that here we have the anterior ethmoid artery, the dimple, and hop, this is the anterior ethmoid artery. And here we are, here we have the anterior ethmoid artery. One should realize that the anterior ethmoid artery here is below the skull base, so it's eligible to an insult easily during any maneuver up there, especially whenever we have a pathology in the ethmoid. On the other side, fortunately, the anterior ethmoid artery is located within the bone, no mesentery, so it's relatively safe. The posterior ethmoid artery, in most of the cases, it is within the bone, the posterior ethmoid artery. We notice here we are, this is the orbital apex, and accordingly, the insult is usually not up there. Again, Grace, anatomy. Here we are, the anterior ethmoid artery, left side, right side, the posterior ethmoid artery, left side, right side, and we can realize the direction of the two posterior ethmoid arteries, transverse. The two anterior ethmoid arteries, oblique, from posterior to anterior and from lateral to medial. From posterior to anterior, from lateral to medial. So usually we can realize it up there during skull base. Now we come to application of all this information, radiologic and endoscopic, to our everyday work. We can visit the skull base when indicated via a transnasal approach, or we may be obliged to visit the skull base via a transethmoid approach. Completely different. We have to plan from the start the indication. Are we going to take care of the pathology in the cell only via a transethmoid, transnasal, or we're obliged for a tuberculum meningioma to perform a transethmoid approach? So it's very important to work together. That's the dialogue and the discussion. What's the best for that particular patient to achieve not only effective surgery, but also safe surgery. The transnasal approach, we understand this is nothing but a diagram, axial, the nasal septum, right side, the sphenoid sinus, the middle termit, first part, and here are, this is the second part, and this is the superior termit. And here we are, this is the, again, skull or cadaver dissection, at Cairo University with Professor Ahmed Zohdi. Here we are. Usually, we use our endoscope. Our endoscope going between the nasal septum and the inferior turbid, and then between the nasal septum, middle turbid, and then nasal septum and the superior turbid to reach the anterior wall of the sphenoid. And from there, we identify the ostium and then proceed inferior turbid, middle turbid, superior turbid, face of the sphenoid, and then we identify the ostium, widen the ostium, and then we are inside the sphenosinus. Hope we can reach the cella if it is our target. We can widen that approach according to our need. Here we are. One of the best way to identify the sphenosinus ostium is to go that way. We go along the floor of the nose, identify the nasal quana, go into the nasopharynx, and then along the roof of the nasopharynx, roof, back to the quana again. The roof of the nasopharynx is nothing but the floor of the sphenoid sinus. Based on the sagittal cut you are having before surgery, we go along the roof of the nasopharynx to identify the quana, and then we go in between the nasal septum and superior turbid along the face of the sphenoid. Accordingly, hope we identify the sphenosinus ostium probe. The distance between the ostium and the quana very variable, so don't measure. Basically, look for the sphenosinus ostium. Identifying the ostium will give you the passage into our target, the sphenoid sinus and sella and planum and clivus and so on, according to our need. Now we are going to apply this endoscopic. Right side, here we are. This is the nasal septum, inferior turbid, middle turbid. We are doing nothing. We are proceeding between the inferior turbid, septum, middle turbid, septum, and then proceeding between, here we are. This is the inferior turbid, middle turbid, nasal septum, floor. Looking along the floor into the nasopharynx. What we did here, we proceeded along the floor, to reach the nasopharynx, to identify the anatomy. When you are inside the nasopharynx, you have to be able and capable of identifying the opening orifice of the Eustachian tube. Very important. Fossa molar, carotid artery, and then quana. Here we are. Identifying the quana, inferior turbid, floor, septum, fossa molar, roof of the nasopharynx, the quana. Identifying the quana. Now we can proceed medial to the middle turbid. Here we are. This is the inferior turbid, middle turbid, nasal septum, right side. Now we are going to just displace the middle turbid laterally, looking for the superior turbid. So now I just want to make sure everybody is following the middle turbid, nasal septum, then the superior turbid. Nice. Now we are able, this is the nasal septum on the right side, the middle turbid displaced laterally, the superior turbid identified, the quana, here we are, face of the sphenoid, and hop, this is the sphenoid sinus ostium, lateral to the lower posterior part of the superior turbid. The superior turbid is very tiny structure, very small structure, but at the same time, it's very important. Anatomical landmark is a very important landmark to the sphenoid sinus ostium. Very important small organ. Superior turbid, quana, and then identify the quana and superior turbid. Now we can proceed to the sphenoid sinus ostium. Identifying the ostium. Now we can identify this is the superior turbid and this is the middle turbid. In between, if just introduce our curved probe, we will be inside the posterior ethmoid. Here we are, middle turbid, superior turbid, and posterior ethmoid. Now, this is the quana, middle turbid, superior turbid, nasal septum, face of the sphenoid sinus ostium. Identifying the ostium, here we are. This is the way we identify the ostium. Now, we have to understand, we noticed during the lecture of Professor Huseman, the posterior nasal artery is coming here into the septum. The sphenopalatine foramen is located just behind the third part or the last part of the middle terminate, just anterior and inferior to the inferior aspect of the spirit. It is here, and from there, the posterior branch, the posterior septal branch of the nasal septum is coming with the sphenopalatine artery. So what we usually do is to preserve the integrity of this area. Sometimes you notice some colleagues, you do nothing, but it offers you no blood, but you destroyed the posterior septal artery. You killed the possibility of a flap in the future if needed, and you destroy the mucosa. There is no good reason at all. You perform nothing but a very smart incision and displace the periosteum downwards, exposing the bone. And accordingly, you can identify the ostium up there and then widen it inferiorly, and then laterally, and then superiorly, and medially, and so on. Preserving the integrity, the mucoperiosteum of the lower part of the anterior wall of the sphenoid sinus. Why? Because we want to preserve the integrity of the posterior septal artery. Now here we are, the blood supply. Here we are, this is the sphenopalatine foramen, from which we have the posterior septal and the lateral nasal. The posterior septal going along the posterior nasal septum, along the lower part of the anterior wall of the sphenoid. The ostium is up there, so preserve the integrity of the mucoperiosteum just below the ostium. Don't cauterize this area. Don't destroy this area. Don't excise this area. Leave it in peace when you are going to need to use it. And here we are again. Here we have this, the sphenopalatine artery dividing, giving you the posterior septal artery into, this is the pterygopalatine fossa, maxillary, and then sphenopalatine dividing into the lateral nasal and the posterior septal. And this is the most important for our target regarding our flap. So we finish our transnasal, but sometimes we want to go via the answers, bulla, basal lamella, posterior ethmoid into the sphenosinus. Usually, we have to identify and re-identify the superior terminate. Very important landmark leads you into the sphenoid sinus. And accordingly, you will be able to visit the sphenoid sinus via the trans-ethmoid approach. Here we are. You may go along the anterior wall of the sphenoid sinus and perform a wide sphenoidotomy or marsupialization of the anterior wall of the sphenoid sinus, performing sphenoethmoidectomy to work along the skull base, the anterior skull base. Here we are, anatomy. Now we have to identify the anslet, the anterior wall of the bulla, the basal lamella, the face of the sphenoid, and then hop, we are inside the sphenoid sinus. The approach, here we are, the anslet, bulla, basal lamella, face of the sphenoid, and then we are here inside the sphenoid sinus. Anatomy, identifying the ostium, we can widen the ostium, marsupialize it, offer a capacious wide passage into which or via which you can perform whatsoever surgery up there. Applying this into endoscopic. Now right side again, the same cadaver, the nasal septum, here we are, and then this is the answer process, this is the bulla ethmoidalis, and this is the middle terminate. Here we are again, the nasal septum, the middle terminate, the answer process, the inferior terminate, the floor of the nose, the quana, and the agar cell. Anatomy again. And then now what we are going to create a window via the answer process into the infundibulum, visualizing the bulla ethmoidalis. Anatomy, anatomy, and anatomy again. Now we did nothing but we incised and dislocated the answer process medially to visualize the bulla ethmoidalis. If we removed this answer process, which is nothing lateral to the medial terminate, we will expose the bulla. Now we are using a through cutting. Usually, we as rhinologists, we don't like grasping forceps. Why? Because the grasping forceps usually destroy the mucosa around the attachment. We use a through cutting forceps to go up there to remove the superior attachment and inferior attachment, exposing the bulla ethmoidalis. We understand here we are. This is the first part of the medial terminate, and this is the bulla ethmoidalis, and this is the third part of the medial terminate. The basal lamella is behind. First part of the medial terminate, second part of the medial terminate, third part of the medial terminate. And here we are. This is the ostium of the maxillary sinus. Now we identify the bulla ethmoidalis. Whenever we are going to visit or go through the bulla, be careful. Always inferior, always medial. Always inferior, always medial. Why? Because superiorly, you are going to get lost into the cranial cavity. Why? Because laterally, you are going to get lost into the orbit. Be careful. Now, we're opening the bulla, inferior and medial. We have our tool, the straight mushroom, the kerison, the tiny kerison, the shaver, the grasping forceps, the through cutting forceps, and so on. We remove the anterior wall of the bulla, anatomy, and then we go up there to the skull base. Careful. Then we remove the floor of the bulla. Careful. And then we take care of the medial wall of the bulla. Careful. And then carefully. And then the posterior wall of the bulla, exposing the basal lamella. The basal lamella. Now the first part of the medial turbinate, sagittal. The second part of the medial turbinate, coronal. The third part of the medial turbinate, axial. So the medial turbinate is very strange. First part, sagittal. Second part, coronal. Third part, axial. And here we are exposing the great basal lamella. We understand the basal lamella is adherent superiorly to the skull base, laterally to the lamina papyracea, medially to the first part of the medial turbinate, and then inferiorly to the third part of the medial turbinate. Anatomy, anatomy, and anatomy again. Now we understand white color, or green, but here red. Be careful. Why? Because skull base up there. If you want to visit the posterior ethmoid via a trans-ethmoid approach, always inferior, always medial. Here we are. This is the medial turbinate. Just to demonstrate, the first part of the medial turbinate is sagittal. The second part is coronal. The third part is axial. The bulla is anterior to the basal lamella. The posterior ethmoid is posterior to the basal lamella. And here we are. This is the basal lamella, anterior ethmoid, air cells, many air cells, small in size, anterior to the basal lamella. The posterior ethmoid air cells are few in number, but large in size. And in many cases, we can identify the basal lamella. And in some cases, because of the pathology, it's hard to identify the basal lamella. So now, the basal lamella, the bulla anterior to the basal lamella, and the posterior ethmoid just behind the basal lamella. Now, if you want to proceed from the anterior ethmoid into the posterior ethmoid, always inferior and medial, The first part, second part, third part, inferior and medial, we created an opening into the basal lamella, through which we can widen using whatsoever a tool. We can use our straight mushroom, we can use our kerison, we can use our shaver. But one should be very careful. Why? Because proceeding superiorly, skull base, proceeding laterally, lamina papyracea, and here we are removing the basal lamella to go into the posterior ethmoid. Going into the posterior ethmoid will give us a very good chance to remove the posterior ethmoid air cells. But whenever we are going up there, one should be able to identify the anatomical landmarks important. The superior turbinate, medial term, and then the gutter in between. We are on the right side, skull base, lamina papularia orbital apex, and here we are the superior terminal. And then we remove the posterior ethmoid air cells, the superior terminal, gutter in between, leading into hop, the sphenoethmoidal recess. And here we are, we remove the posterior ethmoid air cell. We are on the corner up there, relatively white color, the skull base. Laterally, we have here the yellow color, the orbital apex, the optic nerve is up there. And then the bulge of the sphenoid sinus anterior wall may be pink, may be blue, according to the pathology inside. So the corner up there is very important. Sometimes it is created sphenoethmoidal air cell or onodi cell. And here we are, the white skull base, the yellow orbital apex, and then the pink or blue bulging face of the sphenoid. If you want to proceed into the sphenoid sinus, always inferior, always medial. And here we are. What we did here, this is the gutter in between the superior terminate and the medial terminate. Now we are inside hop, the sphenoethmoidal recess. We identify the ostium just medial to the far posterior inferior end of the superior terminate. So it's anatomy, and anatomy again. Now the superior terminate, medial terminate, the gutter, the sphenoethmoidal recess, and now this is the superior terminate. Now just displacement of the superior terminate will lead you into the sphenoid sinus. If you want to get into the sphenoid sinus via the anterior wall, not via the ostium, be careful, skull base is up there. Be careful, the lamina papularia is lateral, and then the third part of the medial terminate, and then the superior terminate. Being aware of this rectangle, dividing it into the red triangle and the green triangle. The red triangle, never skull base, orbital apex. Green, that's it. You can go into the sphenoid sinus. Going into the sphenoid sinus, now the ostium is up there, the anterior wall. So now you can communicate both into and communicating both together. And then widening the opening of the anterior wall superiorly, skull base, laterally, the orbital apex, and then going into the sphenoid sinus. If you identified up there an axial septum like this, beforehand, CT, during surgery, you identified complete septum. So the air cell up there is nothing but the onodi cell. Posterior ethmoid air cell aeration above the sphenoid sinus. And the lower one is the sphenoid sinus. We continue removal of the septum. Continuing the removal of the septum, we go into the sphenoid sinus cavity. Here we are the optic nerve and the carotid artery and the OCR, the lateral and medial. And here we are the planum and the sella and the clivus. So anatomy and anatomy again. The aeration of the sphenoid sinus is very important. You may have a cellular as like this and hypercellular like that you see. And one should be aware, because in this situation, it's very hard. In this situation, it's a very good sinus to offer you very good approach, especially the V2 and the VDN. And you have a very capacious lateral recess as well. The nasal septum of the sphenoid is very important to be identified and taken care of and used through cutting forces, because sometimes it's adherent to the optic nerve and or to the carotid artery. And here we are, the septi, very, very septi. Here we are, carotid artery, optic nerve, carotid artery, and so on. So one should be aware of the median nerve, pterygoid canal, the mouth, and then the foramen rotundum and V2. And here we are in between, we have the lateral recess, where we have, in many cases, the meningocele or meningoencephalocele, what is an approach to the cavernous sinus. One should be aware of the different structures, bulges within the sphenoid sinus, the optic nerve and the carotid artery, OCR, lateral and medial, in between the V2 foramen rotundum, and we have here the median nerve and the pterygoid canal, and here we have the palatovaginal canal, and especially when we are going to take care of an angiofibroma together with the rhinologist. So it's the anatomy again. Now, the optic nerve may be is within a mesentery inside the sphenoid sinus. Here we are, it's adherent to the wall, but here it's an mesentery. So one should study the anatomy. The CT is very important, hand in hand with the MRI. Again, the lateral recess, here we are, we have a very capacious lateral recess, and the pterygoid body here is not aerated. The pterygoid body here is well aerated. The V2, foramen rotundum, and the Vidian pterygoid canal, and the foramen rotundum, and V2, and the palatovaginal canal, pharyngeal arteries. So it's the anatomy. Now, whenever you are working inside the sphenoid sinus and communicating both sphenoid sinus, one should be aware of the flat planum, and then the bulge of the sella, and then the depression of the clivus, and one should be aware of the tuberculum or the chiasm of the optic chiasm, and then the left and right optic nerves, and then the carotid artery along the whole length of the lateral wall, and be aware of all these structures. And then the third nerve, and the fourth, and the sixth, and then the Vidian, here we are, and the V2. And I just want the planum, sella, clivus, the chiasm, optic nerve right, optic nerve left, and then the internal carotid artery, and the OCR in between. Whenever we are working at this area, one should be aware of the anatomy. And in most of the cases at the beginning with Professor Zohdi, we use the navigation to be aware of these structures and avoid insult to the optic and or the carotid. And here we are, one should be aware of the different structures we may visit. Sometimes we can go along the planum. Going along the planum intentionally, especially in tuberculum meningioma, here we are, or along the sella, one should be aware of the different structures. And here we are aware of the anterior cerebral artery and A1 and A2 and ACOM, and again of the optic nerve and the olfactory nerve. And I just want to show you one of our cadaver dissection at Cairo University with Professor Zohdi as well. Here we are just exposing the A1, ACOM, and the olfactory, and ACOM up there. And then here we are. This is the optic chiasm, the optic nerve, and the optic nerve anatomy. We usually resort to the cadaver dissection. The aim of work is to this ACOM and A2, and we can go up there intentionally, say meningioma, craniopharyngioma, and so on. And then here we are. Sometimes we go along the lateral wall with the cavernous sinus extension of pituitary lesion. Here we are. In this situation, one should be aware of, again, the different structures, the internal carotid artery, anterior cerebral, medial cerebral, and here we are, the third nerve, the fourth nerve, the sixth nerve, and the fifth nerve. And here I just want to show you this, one of the cadaver dissection as well. During cadaver dissection, here we are. This is the internal carotid artery, and we are exposing. Here we are. This is the cadaver dissection, and we are just the siphon, and then here we are. This is the relatively thick third nerve, and just beneath, along the fifth, the thin fourth nerve, and then the very long sixth nerve, the cavity, and then the V1. Here we are. I just want to make sure that everybody is aware of the anatomy. Here we are. The third, the sixth, the V1, and the fourth going towards the superior orbital fissure. And then here we are. The V2 is going towards the foramen rotundum. Then one may go along the posterior wall of the clivus towards the posterior cranial cavity in a chordoma, and when aware of the basal artery and posterior cerebral, superior cerebellar, and third nerve in between. So the anatomy should be borne in mind. And I just want to show you again one of our cadaver dissection where here are one of our cadaver dissection, and here are, as we cannot see, this is the basilar artery, and this is the posterior cerebral, and here are the basilar artery, the posterior cerebral, the superior cerebellar, the third nerve in between, the posterior communicating, and the mammillary bodies and third ventricle. So it's the anatomy again. Without understanding the anatomy of this area, you may go up there for a chordoma, definitely hand in hand, because we can take care to the area safely, and we can reconstruct together post removal of the lesion. So it's the anatomy again. Then we can go to visualize this case, or again cadaver dissection demonstrating the internal carotid artery, the whole length. Here we are, the A1, A2, ACOM, anterior cerebral, and then here we are the optic, the olfactory, and then here we are, and then the siphon, and then here we are, the internal carotid artery dividing into anterior and medial cerebral arteries. And this depends on the extension of a lesion. We have to definitely be able to identify the anatomy. And then here we are, this is the, here we are, this is the very nice showing the carotid, the PCOM, the posterior communicating, here we are, and the posterior cerebral arteries. We came to the end of our work, exposing, here we are, this is, as you can notice here, the skull base is curved, it's not flat, and here we are, the anterior cerebral artery and posterior cerebral arteries. We have the frontal sinus ostium, suprasellar, and then the anterior ethmoid artery, the roof of the anterior ethmoid, roof of the posterior ethmoid, and then the posterior ethmoid artery. And here we are, this is the sphenoid. We have to be aware of the different possible complications, because the skull base may be unfortunately entered during your surgery, and we have to understand how low the cribriform is and how high the fovea. And be careful, because you see the anterior cerebral artery up there curved, and any insult to the bone up there, the dura is tiny and adherent, so usually leads to CSF leak. And be aware that sometimes we have aeration of the posterior ethmoid above the sphenosinus sphenoethmoidal onodicell. And here we are, this is the air cell. And be careful whenever you are going to proceed, never and ever superior and lateral, always inferior and medial. Again, here we are, whenever you are proceeding, always inferior and medial, not superior. One of the cases, unfortunately, during pituitary surgery, the neurosurgeon did not go into the sphenoid, but unfortunately went into the skull base, inducing, unfortunately, bad CSF leak. And then whenever you are going to work lateral, parallel to the expected border, the nasal septum, the lamina papyracea, but be careful, because a slight tilt will get you lost into the orbital apex. And again, be careful, any insult to the lamina papyracea will show the orbital fat. Be careful, just push on the globe to demonstrate this. And then here we are, the optic nerve may be insulted within the posterior ethmoid. Again, the onodicell and the optic nerve itself, and the carotid artery. One of the cases here we are, unfortunately, the lamina papyracea all through the posterior ethmoid was taken care of, and the optic nerve was cut. Unfortunately, this situation is too late. Optic nerve, carotid artery, one. So to conclude, neurosurgeon can work together with the rhinologist hand in hand to achieve not only effective surgery, but safe surgery as well. Transnasal endoscopic skull-based surgery. It's the team and the teamwork again. In conclusion, endoscopic and radiologic orientation of the anatomy of the lateral nasal wall anterior skull base is mandatory to achieve safe and effective transnasal endoscopic sinus surgery. We can work together to offer our patient the best. I just want to make sure that everybody of you will be able to get a copy of this. I will send Professor Zodi and Rifaa and Dr. Muhammad the digital or form of it, and it's free from Stoll's company, and you can go through all this lecture smartly and ready for any question. I invite you all to attend our coming Rhino Egypt next March 2nd to 4th, inshallah. So thank you indeed for giving me the chance to be part of that distinguished meeting. Thank you very much. And looking forward for any question. Thank you.
Rida, thank you very much, Rida, for your ever scholarly presentation. I enjoyed it for I don't know how many times. I always enjoy it. And always adding to the knowledge, the anatomical knowledge. Thank you very much.
Together, and only together. Zusammen. Any question, I'm ready to, but and again, anybody who takes who is having any question, you can send it to me, Rida Kamel at rhinology@ridakamel.com, and to Dr. Zodi, to Dr. Rifai, to Dr. Muhammad. Thank you indeed for being part of this distinguished course, and see you soon, inshallah.
Actually, Professor Rida, we have one question about.
Yes, please.
Yes, please. When you have like an unlucky, unfavorable shape for the nasal septum, like an H-shaped nasal septum or previously broken nasal septum or deviated nasal septum, would it make any difference in the approach or the preparation for this case?
In the case of deviated nasal septum, what we usually do is to perform a septoplasty easily. That's the situation of the co-work between the rhinologist and the neurosurgeon, where we can definitely work together to offer our patients the best, inshallah.
Thank you for your answers. Thank you so much.
I just want to add, you may face a lot of anatomical variation, concha bullosa, deviated septum, septal spur, cellular sphenoid sinus, bleeding. So whenever you have your teamwork with the rhinologist, believe me, we will help and offer you a very nice situation during life surgery. Together and only together, zusammen, nur zusammen.
You are sure of this, Professor Rida? You are sure. And yeah, we have another question about if the sphenoid ostium cannot be easily identified, like if it's blocked by thickened mucosa, or if it's not clear where it's readily located in the posterior wall of the nose, or the anterior wall.
Which is structure, the lateral lamella?
No, the sphenoid ostium itself.
The sphenoid ostium is there. As long the CT should be there, the aeration of the sphenoid sinus should be born wide. How big, how small the sphenoid sinus is, always stick to the quina, always stick to the superior termit, always stick to the nasal septum, and in between, you definitely will find it. Probe for it. You will find it. It's the anatomy. If you are not able to identify the medial termit, the superior termit, and the gutter in between, if you are unable to identify the quina, if you are unable to identify the septum, you will definitely get lost. Don't go from up to the sphenoid sinus. Always go from below. go to the nasopharynx, go to the posterior wall of the nasopharynx, to the roof of the nasopharynx, to the choana, go along the anterior wall of the sphenoid. Definitely, you will, and the ostium is there, except if a pathology is within the sphenoid, no problem. You have to probe for it, widen it, preserving the integrity of the mucoperiosteal flap, preparing it for any possible future nasoseptal flap.
Okay, thank you so much. And this is another question about the lateral lamella. If there is any special slope in the preoperative CT, we can detect the special slope or angle which make it risky during endonasal approach.
This is very interesting and very important question. Thank you very much. Sure, the CT should be there. The coronal section is very important. The anterior cuts, very important. We have to study and restudy. And we have our classification type 1, 2, 3, but no problem to identify which of which. But we have to understand how long the lateral lamella is, because definitely if it is too long, it's very easily prone to insult. The lateral lamella is tiny, very thin, 0.02, 0.05 millimeters. So it's nothing. Appreciate this whenever you apply light below and look up via a dry skull. Hop, it's very thin, very legible for an insult. So the CT should be there, and definitely working with the rhinologist, he or she, we work there every day, exactly like you work up there every day. So we can meet together at the lateral lamella. You are from up and I'm from down. Exactly like the very nice slide Professor Zohdi usually shows us during his lectures. The car, somebody is looking at the car from below, the other one is looking at the car from above. And believe me, whenever we look up, very strange structures. And definitely it's the same for you whenever you look at the same structures from below, especially if you are going to use the endoscope.
So much. Very comprehensive, yeah. Question. Thank you, Professor Reda. As usual, one of the best lectures. Thank you so much.
Thank you, and looking forward, and see you soon. Bye-bye.
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 And then we'll go for Professor Henry.
Bye-bye, Reda. Thanks for joining.
Oh, Henry, nice to see you. We missed you a lot of times, and hope that we have you during our Rhino Eve this year, but next time, inshallah.
Of course, we will have